Hi, I'm Vic Perry and welcome to our podcast, brought to you by Living Positive Victoria, the Australian Research Centre in Sex Health and Society, and the Alfred Hospital Education and Resource Centre. And today we're going to be covering HIV and treatments. And joining me today is Jennifer Power, Coordinator of the HIV Futures Survey at Trobe University, and Jenny Hoy. And Jenny is the Director of HIV Medicine at the Department of Infectious Diseases at the Alfred Hospital and Monash University. Today we're talking about the findings of the latest Futures Survey in regards to treatments. Now, before we go into the specifics, Jenny, would you like to give us a bit of a background to the Futures Survey?
Sure. So HIV Futures is Australia's really longest running survey of people living with HIV, a study. We began it in 1997, and at that time highly active antiretroviral treatment had just become available in Australia. So we were really interested in tracking health and well-being of people living with HIV in this new era of treatment, I guess. So what we've done since then is repeat the survey 8 times, so every 2 or 3 years since 97. Most recently in 2016 with HIV Futures 8. And we've looked at a range of issues. So we've looked at physical health, mental health, general well-being, life experiences, so relationships, and certainly treatment use as well over that period of time.
Which is what we're talking about today. So what does Futures 8 tell us about people and treatments and their experiences with treatments?
Look, it tells us what we really expected. So we heard from just under 900 people living with HIV in Australia. 96% of those were currently taking treatment for HIV. That's probably, it's probably slightly higher because we were more likely to hear from people who are engaged in services. Just the nature of recruiting for the survey meant that. People who are less engaged and or people who are newly diagnosed and maybe not commenced treatment yet were possibly less represented in this study. So it was high. We also we asked people when they were diagnosed, and we did find that among people who were diagnosed in the last 5 years, just over 60% had commenced treatment within 3 months. So people were commencing treatment quite early, but there was 20% within that newly diagnosed group who had waited over 12 months to start treatment. So I think that's probably something that'll be interesting to watch over time, just to see if that 20% gets lower and we're seeing more and more people starting treatment early.
And that is interesting, and I guess we would expect to see changes. Yeah. So Jenny, in your clinical experience, particularly with people who are newly diagnosed, what have you seen in terms of changes over time?
So I think we're seeing similar changes. The way that patients approach treatment is often based on experiences from friends or peers, what they read online, but also what they're told by their doctors. And the doctors, hopefully, use evidence, clinical evidence, to base their recommendations on whether to start treatment early or not. And in fact, it was in 2015, the year before this most recent Futures Survey, that the results of a landmark clinical trial that involved over 4,000 people worldwide were released, and the results showed that there was clinical benefit to early treatment. And since that time, more and more data has become available from the START study, showing that there's better quality of life from starting treatment early. There's more and more data saying there's benefit and not risk from starting treatment. So doctors changed their attitudes with this medical evidence and started offering treatment around the time of diagnosis. And more people are taking it up rather than deferring.
And in addition to that, in that, I guess, context, also, I know from my experience in talking to people in a community setting, there's not only the advice that they're getting from their GP, which is changing it and heading towards more to starting treatment early, but as you mentioned before about peers, that's incredibly important now, and how influential that can be, where, and we've mentioned this in another podcast where we talked about the very fact that today there's a much bigger chance for a person who's diagnosed to already know someone else who's diagnosed, and in particular someone on treatment, and to see the experiences of other people on treatments and how well people are doing today gives people a lot more confidence to decide to go on treatment straight away as well.
Yes.
So if their partner or a friend is already doing well on treatments, then they'll think themselves that, oh, okay, I can see it firsthand that it's not that bad.
Yes. Yeah.
And that's certainly happening a lot today. And in terms of transmission as well, that's another area where I guess people who are newly diagnosed are getting more confidence and almost enthusiasm. And I see people thinking, yeah, I want to go on treatment straight away because I want to minimise my chance of passing on HIV.
Yeah.
I know the science, I've read all this stuff about, minimising the risk by being undetectable, and undetectable being that while you still have HIV, but you're successfully suppressing the virus, can almost zero risk can happen when one has a suppressed virus. And we say almost, and I guess from your scientific perspective, why do we say almost zero?
I think that it's a concept that's very difficult to actually explain to people who don't have a maths or a biostatistical background, but because the numbers of people that were involved in the trials looking at transmission in individuals that are virologically suppressed, undetectable viral loads, there's still that element of uncertainty. You would need thousands and thousands of people to say definitively there is absolutely no risk. So we have this concept of a 95% chance, and that is very low, very, very low, but it's still there, which is why we can't say you definitely can't. Yeah.
What we've seen in Futures, I think between Futures 7, which was done in about 2012, 2013, and Futures 8, which was done in 2015, 2016, is evidence, I think, or some indication that new evidence around the very, very almost zero risk of transmission is starting to filter through. So we'd always ask this question about the extent to which people were concerned about transmitting HIV to sexual partners, and we'd found that had gone up consistently since 97, and the first time it started to go down was in Futures 8, and that corresponds really well to when several major studies released their findings showing that transmission was so low, and I think people are starting to feel more confident about that.
And PrEP, which has just been introduced, I guess, fairly recently as well, in terms of a factor in transmission rates. And this will probably come out in the next Futures.
I think so.
The next couple of Futures where there'll be even more confidence, even though Futures is about positive people, but they're knowing that their negative friends or people that they know, and the confidence that they see in the general community about transmission and the factors that PrEP is making an even bigger change.
I think the psychological benefits of PrEP for positive people is something that we'll start to see, absolutely, over the next few years.
So in terms of people who have been on treatments for a long time, and I guess as we do become more and more enthusiastic about getting people on treatment straight away, so we've got large numbers of people on treatments for many years. How about fatigue? Is that an issue that is impacting on how people are taking treatments? And is it to the point where people are stopping treatments? I don't think it is. I for myself personally, I think of fatigue. I think, I'm fatigued from taking treatments every day, but it doesn't stop me from doing it. I still do it. But I can understand the concept that it is some kind of, I guess what word might be, not indifference, but you get tired of just taking pills every single day. What do you see in your clinical experience?
So I see a couple of things. I see people who are starting treatment in recent times with the newer medications, one pill once a day. It's like taking a pill for high blood pressure or high cholesterol. You have to take those you have to take this pill for HIV. So, and also the most recent medications have less side effects than the older medications. So they're easier to take and they're easier to remember, and I don't see fatigue entering into people's minds at this point. It's actually the people that I've been looking after for 20 to 30 years that are on the older, have been on the older regimens. We're looking at trying to simplify the regimens, trying to cut down the number of pills, being a bit more confident in being able to do that. And individuals are very happy with less pills because as we age and we do get the comorbidities of high blood pressure, high cholesterol, diabetes, there are numerous medications that need to be taken for those conditions, and when you add those medications onto a number of medications for HIV, that's when people start to say, oh, I'm really sick of this, can't we simplify things? When you do simplify, you're much happier.
We did find in HIV Futures that people aged over 50 were more likely to report experiencing side effects from their HIV treatment, but that was actually irrespective of how long they'd been on treatment. So even people aged over 50 who'd been diagnosed in the last 5 years, the numbers were small, to be fair, but even among that little group, they were still more likely to report experiencing some side effects than younger, newly diagnosed people.
And perhaps that's because as we age, we do get aches and pains with osteoarthritis, we do get other symptoms, shortness of breath, if you're a smoker or asthma, etc. And we tend to lump them all into this is caused by HIV or this is caused by the treatments, when in fact they're not. They're caused by the other conditions that we're experiencing. And I think it's a problem when we do start looking at every symptom, every abnormal blood test is due to the HIV medication, when that's not the case. So,
but it's hard to know what's what when you...
As an individual, you can't know. You're reliant on the advice of your doctors and nurses that are overseeing your healthcare to explain to you that this is due to HIV, this is due to the meds, we'll change the meds, this is due to something else.
And in terms of the I guess if we wanted to convince people out there whether it's worth going on treatment or not, or what the benefits are, in terms of the research, it's been pretty consistent lately, hasn't it? The long-term
so
benefits
the
of
long-term benefits are there. There's a reduction in the comorbidities that we measure. For example, there's a reduction in heart attacks, reduction in cancers related to immunodeficiency, low levels of immune function. In the long term, they're all much better on treatment. And we're also seeing many more studies now suggesting almost normal life expectancy as the person standing next to you without HIV. So that's an exciting gain that we've seen with the newer treatments.
So do you find people who are newly diagnosed, do they have concerns about commencing treatment, do you find? And do you get a sense of what the things are people worry about?
So that I guess I might see a different group of people working in a hospital clinic or on the wards. I see people who perhaps have more advanced immunodeficiency. It's very easy to suggest that treatment is really good at this point. For those that have normal CD4 cell counts that come to a hospital clinic, they often do not know anyone with HIV. Often much more isolated. They don't go to the high caseload general practices. They're more reliant on what advice I can bring and what information I bring to the table. And so then it's all about how you deliver the information around the benefits of antiretrovirals. Because I believe in it. I would would suggest that it's a good thing to do. And those individuals, usually, I do have a couple of people who are less confident about starting treatment, who continue to question, and we go over the data each time they come in as we measure their CD4 cells. But in general, most people are happy to start treatment. They think, I've got a condition, you've got treatment, why aren't I on it?
Yeah, doing something about it.
Yes, exactly.
And it's interesting, I remember, I think it was Dr. Mark Chung who said at a conference that it was interesting that HIV was one of those things that, and different to every other bacteria or virus that we get, that as soon as we get something, we treat it. Yet HIV has been one of those things that we had waited and waited and waited for obvious reasons, but
Yes.
it was a wait and see kind of thing.
Well, we can go back as far as just AZT monotherapy. If you remember, there was the Concord study which randomised people with over 500 CD4 cells to AZT monotherapy. And because AZT was not a good drug, it didn't work. The study showed you need to wait. And so until we have had access to good, potent drugs with minimal side effects, it's been so much easier.
Yeah. And really that's, if we look at data from Futures, you definitely saw a decrease in the early 2000s in terms of the number of people on treatment, and then it's just gone consistently up since then. So even post 97, it didn't seem like it really got easy until 2004-ish.
Well, that's when the newer classes,
Yeah.
The integrase inhibitors,
they made a much bigger difference.
Enormous difference, yeah.
Okay, well that's another wrap for another vodcast. Thanks for listening. I'm Vic Perry, and thanks Jen, and thanks Jenny. And make sure you keep an eye out for our other vodcasts on a whole range of other topics. I'm Vic Perry, thanks for watching.